Our flight is on time.
Hello, everybody. Thank you for joining us. I'll give everybody a second just to get settled in here. So before we start with today's webinar, I just wanted to announce some of the upcoming webinars that we have for the end of the year. Next week on December 9th, Anna Meyerhoff will be presenting on industrial hygiene on the farm, communicating with the agricultural community about PPE and ergonomics. And that's in collaboration with the New York, New Jersey Education and Research Center. And then our last webinar of the year on December 17th, we'll have a group webinar from Mercy Omuifo Irefo, Amor Cornelius Dondi, and Dixon Rangere, who will speak on their research on job rotation, and that's in collaboration with the University of Cincinnati. And for more information and also to register for those webinars, you can visit cueh@berkeley.edu/webinars. And we'll also have some upcoming webinars in the beginning of 2026. So look out for that. So I'm excited to introduce our speakers for today's webinar, Collaborative Care in Motion, the Power of Nursing and Ergonomics in Workplace Health. Just a few housekeeping items first. You're going to be muted during this presentation, and if you would like to ask a question, please enter it into the online Q&A box, and that's at the bottom of your Zoom toolbar. We'll save some time at the end of the presentation to address as many questions as possible, and we'll also have the chat open, so feel free to use it to participate and join the conversation and talk to your fellow audience members. The presentation is going to be recorded and will be made available on the Center for Occupational and Environmental Health YouTube page within 5 business days. And our presenters have also graciously allowed us to share the slides, so feel free to email us at cuehce@berkeley.edu to get a copy of those slides. All participants who logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to an evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. And we're also accredited this webinar with BRN, so you'll also get a contact hour for that. Once the evaluation is completed, you'll be able to access and print your certificate. Now, I'm pleased to introduce our speakers, Melanie, Alexandre, and Rangineh Bassir. Melanie Alexandre is a Berkeley Lab Environmental Health and Safety Department and serves as Ergonomics and Injury and Illness Record Keeping and Incident Review Program subject matter expert. She's a certified professional ergonomist who holds degrees in occupational safety and health and occupational therapy. Melanie has focused much of her 30-plus year career on ergonomics. She loves to partner with individuals and groups to help establish effective ways to improve workplace safety. And Rangineh Bassir is a nurse practitioner and occupational health leader with over 15 years of experience in occupational health, case management, primary care, and urgent care. She currently serves as the health services manager at Lawrence Berkeley National Laboratory, where she leads programs that promote employee wellness, safety, and clinical excellence. Rangineh is board certified as an adult nurse practitioner through the American Nurses Credentialing Center and as a certified occupational health nurse specialist through the American Board of Occupational Health Nurses. Rangineh and Melanie, thank you so much for being here. I'm going to stop sharing my screen and we can get started. Thank you.
Thank you. That was a mouthful. It was a tongue twister. Rangineh, would you like to begin? Few words?
Sure. Hi, everyone. As Will mentioned, my name is Rangineh Bassir, and I'd like to reintroduce my esteemed colleague, Melanie Alexandre, in the Berkeley Lab Environment, Health, and Safety Division. Melanie serves as the subject matter expert for the ergonomics program, as well as the injury and illness record keeping and incident review programs. She is a certified professional ergonomist with academic training in occupational safety and occupational therapy. With over 30 years of dedicated experience, Melanie has focused her career on advancing ergonomics in complex work environments.
And I have the honor of reintroducing Rangineh Bassir, who's a nurse practitioner an occupational health leader with 15 years of experience in occupational health, case management, primary care, as well as urgent care. She is currently the health services manager at Lawrence Berkeley National Lab, and she leads the programs that help to promote all of our wellness, safety, and clinical excellence. I want to thank Rangineh for coming up with this idea for a webinar. As I thought about this and we were preparing for this, I realized that this partnership feels very easy, very common, but I actually, as we were preparing this presentation, I really identified this is really something quite special, our partnership, and I'm really happy to share this with you. So, and I want to just make a reference that Rangineh and I have, these aren't just good ideas that we've thought of, that we have relied upon the research and the evidence and the literature to help support us in our programs. And so we have if you wanted a copy of our slides, we have all of the materials that we've used to support our programs from occupational health nursing, from ergonomics, as well as total worker health that you can reference at a later time. So thank you for being here today.
Thanks, Melanie. So our agenda topics today include where we work and how we intersect and overlap. We will review a couple case studies, then we'll review how it all comes together, and we'll end with benefits and key takeaways.
All right, so we wanted to start by just sharing with you where we work. We work at a very unique, very special place, as well as our roles. And we're really going to highlight today how we intersect and overlap on a daily basis. So we both work at Berkeley Lab. The lab has been around for about 90 years. At any given time, we have about 4,300 employees, and that varies because we're a teaching facility. So we oftentimes, at certain times of the year, have lots of students with us. The University of California manages the lab for the US Department of Energy. And our research really focuses on science and solutions for having abundant and reliable energy supplies. We have 5 user facilities, so we have people from around the world using our users' facilities, and 17 of our staff members are Nobel Prize winners. I like to view our campus as kind of a mini city. So in order to do great science, it takes a village, and we have about 22 different scientific divisions, and we have 7 partners within our operations divisions that make all this magic happen. So we work at a really cool place.
So the occupational health nurse, or OHN, role focuses on health promotion and disease prevention. We provide case management for injuries and illnesses. We are big on collaboration and advocacy for our patients. We provide program leadership and ensure compliance. And as professional, competent clinicians, we provide competent clinical care and education. In general, we focus a lot on trust building, advocacy, partnership, and empowerment of our patients and our colleagues.
Yeah, so that's Rangineh's role. And I have many different hats, just like Rangineh. One of which is that a big part of my day is spent doing risk assessments and helping with safe work planning. These are kind of essential to the core of my daily work. I work with individuals and groups to make sure that we're reducing risks such as repetition force, awkward postures, looking at different material handling hazards, and identifying how we can control these potential risks. Our program is strongly aligned with all of our new projects, our new building construction. So we really emphasize the importance of ergonomics in the early planning stages of the things that we do at the lab. I wear a complementary hat to ergonomics, which is our injury and illness program. And so I also oversee all of our OSHA record keeping and our incident investigation reporting. So this means that I have access to information about our work-related incidents, not just ergonomics. And so this really helps. I know that, injuries are a lagging indicator, but this really helps to put me in a good position to closely examine any emerging trends, any reoccurring themes, and it helps us to steer our ergonomics program into healthy directions. I also do individual, group, or even design reviews that make sure that human factors are identified and properly controlled. And we have a luxury, which is we have what are called ergo advocates. These are people that have, as part of an adjunct duty, they do a lot of our preventative ergo evaluations, whereas our ergonomics team can then focus on more complex industrial, laboratory, and discomfort evaluations. So it's very common in our work setting that we might be doing several ergo evaluations for the same person to be very holistic in addressing all of their work areas. And then we also focus on injury prevention and accommodation. And this is where the health services team and ergonomics, we are fully integrated into these efforts. And we're going to dive into this a little bit further in just a few moments. And then another component is working on training and education, that our program is really structured to align with evidence-based practices. So a lot of what we do is either one-on-one or group. It's really structured on evidence-based ergonomic principles, as well as adult learning theory principles. And I often view myself as a salesperson of ergonomics, that I really want to feel, just like Rangineh, that people are empowered to make decisions and they understand the why and the how, certain recommendations are being made so that they can make informed decisions to have good buy-in to the things that we're advocating. So this is where the magic happens. If I could earn frequent flyer miles for all of the times that Rangineh and I are interacting and collaborating, I would be flying around the world over and over again. And so we really wanted to dive into all of these points of intersection and overlap that we work together on, in the hopes that this might inspire some of you to follow some similar practices. So we both have a seat at the table when it comes to our case management. We meet formally on a monthly basis, and we meet informally all of the time. And whether that's working on workplace accommodations or whether we're working with someone who we think from an ergonomic standpoint, they might need some health services support as well. We help with people who, for example, this is one that reoccurs quite commonly, is that we might be working with someone who has some written work limitations and maybe they need to be taking breaks every so often. And so this is something where the ergonomics team can meet and show them some of the resources and work with them very closely to help to complement that support that the clinicians are giving them. Of course, we both want to prevent injuries from occurring in the first place. And so we actually have a group where we meet on a monthly basis to review potential high cost, high risk cases. And these are typically cases that involve potentially lost time. And we really want to utilize data and information that will help us to understand how we can prevent these injuries from reoccurring, how we can get people back to work. And Rangineh and I have several tools at our disposal. We have a dashboard that helps us to pinpoint and target whether it's certain at-risk job areas, whether it's to spotlight certain emerging trends. So we're always trying to be ahead of the game in injury prevention. We partner very closely when it comes to return to work situations. And I do want to just acknowledge that this is for occupational and non-occupational injuries. So we identify that even when someone's had a non-occupational injury, that they might need some help with accommodating them. A very recent example of this is someone who had a non-work related injury that required them to elevate their leg throughout the day while they're working from home. Well, the health services team pulled us in and we were able to come up with some solutions to help this person to continue to work while still meeting their work accommodations. We allow and welcome our health services team to have full access to our ergonomic evaluation system. So they could not only request evaluations on behalf at any time, if they are working with someone and they think an ergonomic evaluation might be warranted, but also they have view access to our entire ergonomic evaluation system. So if they want to go in and see what's been going on with that person, and they maybe want to help to reinforce something that we're working on with them, we have this very complementary relationship, and they have full access to our ergo evaluation system. We work together on promotions and wellness initiatives. We'll be sharing with you an example in just a moment, but whether it's some annual events or safety fairs, we both participate in our monthly healthy and wellness newsletter. These are things that are very important for us to have good visibility and good cohesiveness in our messaging. And we do a lot to promote education. We've partnered together on several presentations, whether they're formal or informal or meetings. We really want to empower employees to understand how to be advocates for themselves and to focus on their wellness. And this might be unique to some of you, but we have a collaborative process for our onboarding. So all of our new occupational health nurses, we have an onboarding resource so that they get to know about our ergonomics program, so that we don't want people to have any, we don't know what preconceived notions they come with. But so we want them to really understand that as part of this onboarding, that we are strong partners, we align, and here's all the places where we can work together on. So we actually have this as part of an onboarding process for all of our new nursing staff. We want them to very early on understand how critical this relationship is. And health services has a new hire health screening resource for our employees. And as they're doing this health screening for a new employee, and they identify that someone might have a need for an ergo evaluation, or they maybe have a prior issue that they're coming to us with, they can request an evaluation, and we can get to see someone very early on in their career. So we didn't want this to be we wanted this to be very concrete and nothing abstract. So we wanted to share with you some case studies. So we've prepared a case study on an office situation, as well as someone who does physical manual tasks. So our first case study we wanted to share with you is someone that started off by connections with our ergo team. This is an employee who had completed their annual office reassessment and training. This is a requirement that we have on an annual basis. And we have in that training a question that asks the person if they would like some ergonomic assistance. And if they say yes, that automatically triggers an evaluation to our team. And we consider that anyone who speaks up about having discomfort, we treat that as a high priority, and we arrange to do an ergonomic evaluation within 2 days of getting that request. And so this particular employee completed their annual self-assessment. They indicated they were having some discomfort. We scheduled an evaluation with them. Come to find out, they're a hybrid worker. So they're on site 3 to 4 days, and they're teleworking 2 to 3 days a week. It kind of varies. And so we actually arranged to do an ergonomic evaluation for both of their work areas. We did one for them in person, as well as one via Zoom for their telework setup. Well, during this first meeting, we identified that they had had a situation where they had some increased workload over the past few months. They were skipping their breaks. They were working on weekends. They were working longer hours. and they started to have experience some discomfort in their right wrist and hand. And this had been going on for several months. And so when we met with them, their on-site setup was not too bad. We really just made recommendations such as discussing their workload with their supervisor, installing a site license software for break reminders. So when they get in the zone and they might forget to move and change positions, they can have a tool to help them to be mindful of that. And then we suggested that they maybe give their right hand a break by looking for some alternatives of different pointing devices. As well as we discussed some AI tools that they might want to use for note-taking and some speech recognition tools that were already integrated into their system to help with things like Gmail and Google Docs. So we scheduled a follow-up 2 weeks later, and their discomfort was improving, but it hadn't completely resolved. So the ergonomist recommended that they check in with health services and just make sure we were on the right track and make sure that there weren't any further interventions needed. So the employee agreed to do so. They checked in with health services. Health services determined that this was just a mild case of tendonitis. They concurred with the course of action that we were taking. They did provide the employee with some first aid treatment. They gave them a soft brace, some ice and heat. And then 2 weeks later, we both followed up with them for separate meetings, and their discomfort was improving. They didn't think any further changes and interventions were needed. And then at that time, we were able to duplicate what we learned for their on-site setup to their telework setup as well. And then we just continued that process until it was fully resolved. So this is an example where we partnered together and the ergonomics team initiated the interactions. Now I'll turn it over to Rangineh to share another.
Thanks, Mel. So in this case, the injured employee sees the OHN first for a repetitive strain injury that happens to be a back pain in this case. The employee's job duties include frequent lifting, pushing, and pulling greater than 50 pounds. The OHN provides clinical care and education for the injured employee and recommends EAP as well as an ergonomic evaluation. The employee is initially resistant to the ergo eval. He mentions that he's been in this role for over 20 years and he feels very confident in his ergonomic practices. After further education and encouragement from the OHN, eventually the employee agrees to an ergo eval. He's pleasantly surprised because the ergonomist provides guidance on proper posture and introduces helpful new tools that the employee was previously unfamiliar with. The ergonomist then collaborates with the supervisor and safety team to implement the recommended administrative and engineering controls. The ergonomist then closes the loop with OHN, shares the findings and recommendations, all while maintaining confidentiality. In this case, the employee benefits from ongoing follow-up with OHN and ergonomist until even after the case closes, and that is for prevention of future injuries for this employee. And that's, as Mel mentioned, that's our practice for all injured employees to empower them as much as possible. The most important outcome in this case is that the OHN and ergonomist advocacy empowers the employee, reduces stress, and supports recovery from the work-related injury.
So we wanted to highlight one of these collaborations in motion that was actually really fresh in both of our minds. This just happened for the month of October. Is that we had an injury prevention campaign that we called One Small Change. And we called it One Small Change because we identified that it's often little things that you can do to change and improve your ergonomic situation that can have big impacts on your comfort, health, and safety. So that was kind of the driver behind this. And so really we were focusing on having this kind of come at people in many different directions, because we know that certain things will stick with some and other things will stick with others. And one part of this that I thought was the most powerful part of this campaign was having testimonials from our senior management team, from our medical director, from a supervisor, from a new employee, from one of our ergo advocates, as well as an employee who had experienced discomfort. And they shared their experience and what their one small change was, in the hopes that this would promote and encourage and inspire others to make one small change for themselves. And so we have a newsletter that goes out daily. And so we were featured in that on a weekly basis. We hosted a lunch and learn. Both health services and the ergonomics team hosted some booths at a lab-wide event. And we offered prizes, which is always helpful to do. And I just want to point out that if you were so interested, that QR code will take you to our One Small Change website, and you could see what this campaign was all about in greater detail. And we did survey many of the employees who participated in the One Small Change campaign. And we just wanted to know, did they change anything? And if so, what did they change? And we really found that, you know, a fair amount of people made changes to their equipment or to their posture. Others committed to being able to try to walk, stretch, and use our break reminder software more often. Others tried to change a habit. And then a small percentage actually asked for help in addressing their one small change. So this was a very much so a great example of injury prevention campaign that we partnered on together. So now let's talk about how it all comes together. Is really the idea of this is why ergonomics and health services in a workplace setting can be so important, is that it can really help to change the culture of wellness, reducing injuries. And there's a lot of evidence to show that it can reduce the costs of injuries, the severity of injuries. It can really help with effective case management and disability management. And it really changes the feel and the tone of our culture. That if you're prioritizing this and this culture of continuous improvement that's even integrated into your personal safety and comfort, that can go very far. And I don't want to discount the importance of supervisors being active participants and empowering supervisors, because they have an active role, like in that case study that we talked about, is that the ergonomist and the health services team doesn't necessarily influence the workload, but supervisors can. And so we really identify that we want them to be a critical team member in their employee well-being and preventing injuries. And so all of these things come together and benefit employees, supervisors, the organization, and the overall culture and wellness. And so we're going to discuss each of these in a little bit more detail. So these are actually things that are well documented in the literature. Is there are effective benefits to the employees, that when you have this cohesive total worker health program, it can reduce the severity of injuries, the reoccurrence of injuries, and it really helps employees to feel heard and supported. And in a lot of ways, you know, we're empowering employees to be advocates for themselves and to really understand how to care for themselves and making themselves a priority. So there's lots of benefits to the employee. There's also lots of benefits to the supervisor. Is it really helps in them having tools to prevent injuries, to promote well-being. And we really encourage supervisors to discuss workload and employees' comfort during their one-on-ones with their staff. We have a whole section of our ergonomics website that is dedicated to supervisors and giving them some tools to be effective partners in employees' wellness. And we continue to encourage a culture of improvement and continuous growth. And when you're benefiting your employees and you're benefiting your supervisors, you're also benefiting your organization. And this could go far in reducing your lost day cases, your claims, the cost of your claims. And this strong collaboration is not just with Rangineh and I. It's with our health, with our supervisors, our human resources, and our various safety teams. So we're not on this island alone. It's very much so collaborative.
So Mel is absolutely right. We're all about collaboration with each other and our patients and employees and our various colleagues. Our collaboration benefits employees with non-occupational and chronic conditions as well. Some examples include pregnancy-related discomfort or musculoskeletal injuries that are not work-related. Applying ergonomic and clinical insight together supports total work health, reinforcing the idea that prevention and well-being are part of workplace culture and not just compliance. One valuable outcome of our collaboration is the cultural shift, where wellness becomes a shared cultural value and not a program. Wellness then is accepted and normalized as an integral part of organizational success. As we approach the end of our presentation, we wanted to review some benefits and key takeaways. So some of the benefits of having on-site health, we wanted to review some of the benefits of having on-site health clinics and on-site OHNs. Benefits of on-site health clinics and having OHNs on-site include early intervention. It ensures easy and fast access to the on-site OHNs instead of people taking further time to travel outside work and wait for appointments that may take 10 to 15 minutes for evaluation. Better return to work outcomes. As mentioned, OHNs are great at collaborating with ergonomists, HR, legal, supervisors, and other stakeholders to advocate and facilitate timely and safe return to work. Proactive prevention is another benefit. OHNs create and implement wellness programs. They play a significant role in patient education and health coaching. About cost and time savings, on-site OHNs play a key role in reducing lost and restricted workdays. That's through ongoing partnership, case management, and advocacy. Another benefit is compliance and risk reduction. OHNs ensure compliance with applicable laws and regulations, including OSHA, ADA, and workers' comp requirements. This results in reducing liability and strengthens audit readiness. Lastly, OHNs improve culture of trust. A proactive OHN boosts morale, trust, and retention by promoting total work health.
And the literature has lots of evidence to show that on-site ergonomic programs could have numerous benefits. And as I've mentioned before, all of the sources that Rangineh and I have been referencing, we've cited at the end of this presentation. That ergonomic programs could, impact productivity, reduce errors, reduce absenteeism and turnover, and could really help to reduce musculoskeletal disorders, fatigue, and really show a strong investment in safety culture. And there are several peer-reviewed studies and literatures that show the benefits of combining on-site health services and ergonomics program. And these are often called total worker health programs. And some of the key findings in the literature point to the positive impacts on musculoskeletal disorders, that they really identify that if you have on-site, a combination of on-site support, that really goes far in addressing the total physical needs and mental and emotional needs to help with recovery. There's also evidence to show that these multifaceted programs that might include nursing, ergonomics training, maybe exercise program, equipment modifications, education and training, these have very good positive functional outcomes. And all of this, to be said, is really, it creates a framework for an integrated approach for health promotion and just integration into the fabric of how you do business.
So our work shows that collaboration isn't just additive, it is indeed transformative. When the clinical and ergonomic perspectives come together, we don't just treat injuries, we change how people experience their work. We would like to invite you to think, how can your teams strengthen the connection between care and prevention?
Wonderful. Thank you. We are at our questions portion. Thank you so much, Melanie and Rangineh. We have a few questions coming in right now. I have a first question from one of our audience members. Which ergo evaluation system are you using when you first bring an evaluation to an employee? This is from our ergo people in this webinar, which I'm sure there are plenty.
Yeah. So our first line of defense is an online training and education resource. And we use a company called COHN-S to administer that. And so this is a way that any employees who work on a computer 4 hours or more a day, it's part of their work planning activity. And so it's a required training for them. And then that gives us the luxury of binning people based on their risk levels. And then we can then do targeted outreach to the people that maybe were flagged as moderate and high risk. So that's kind of the first line of defense, is that training system. And then we have a homegrown system that we keep as a repository for our ergonomic evaluations. And that, we're very much so about interfacing with the customer and spending very little time with paperwork. And so we have a very simple ergonomic evaluation tool that we use. What were the problems? What do you recommend about them? And what are the actions that we need to take? And then we have a way of documenting all of our follow-ups and specific recommendations. Yeah, I don't know if I'm answering it properly, but that's kind of the whole continuum of, and then when it's an industrial ergonomic evaluation, we have a template that we utilize, and it really just depends on the nature of the ergonomic evaluation of what information and data collecting we're doing to help to do that analysis. And so those tend to be a little bit more free form in terms of the industrial type ergonomic evaluations. And if it's for like a work task instead of a particular individual, we approach those a little bit differently so that we're kind of providing a different tool. Sometimes we'll even put our ergonomic evaluation on a PowerPoint slide deck so that we can be sharing it and collaborating with those end customers.
That makes a lot of sense. You have targeted evaluations depending on the situation and the individual. It's very cool that you also have your kind of own homegrown system. And that brings me to my next question, which, I was also thinking during this presentation. Somebody asked, you have a very mature ergonomics program that is well integrated with Occ Health. Please discuss how long it took for your organization to get to this point, and what tips do you have for making this successful? I mean, I was thinking the same thing. It just seems like it's so well developed, and it's so clear that you collaborate so well. And, was there a point where the lab only had, say, an ergonomist and no on-site health clinic and no Occ Health nurse, or, how did it come together? What's the history of it?
Rangineh, do you want me to take that? Since I'm the old goat, I've been around a little longer. Do you want to chime in?
And I'll let you elaborate on that, and I may chime in with what I've seen in the more recent years.
And also
Yeah.
feel free to take your time. We have a good amount of time for questions, so no rush at all in telling the history and whatnot.
Thanks, Will.
Yeah. So I don't go back the 90 years that the lab's been in existence, but I've been at the lab since 2007. So I've been here quite a while. And for my entire tenure, we've always had both programs. And so I think maybe that's something that was kind of a helpful thing because we were always working together and interfacing in some way, shape, or form. But I will tell you, and I get why someone's asking this question is you want to see underneath the hood all the ugliness that maybe happened to get us to this point. In my experience, I've always had a collegiate, very collaborative relationship with our health services team that's always been in place. I think where it's kind of gone up a notch is that just we agreed mutually that there's a win-win and we just have more touch points that we're interacting with. So I see that it's always been in place, but now we have a lot more touch points that we've decided for ourselves that work really well for us to interface and interact. And so we just took a strong foundation and just made it stronger. So I'm sorry to say that I don't have a bunch of dirty laundry that it was awful and terrible and we hated each other, because that's never been my experience, that we've always kind of had some connections and they just continue to get stronger over time.
Rangineh, anything to add?
I agree with everything that Melanie just mentioned. I know we have probably mentioned collaboration 20 times at this point, but I will mention it again. We collaborate and we work well together, not only Melanie and I, but Melanie's team with our team at Health Services. We communicate, we over communicate, we trust and respect each other. We have faced some complex questions about some groups around the organization where we put our heads together and came up with a great solution because again we collaborated well, we respected each other's solutions and ideas, and we and others were impressed when we went around and campaigned or presented those solutions. So there is a lot of value, and I can't emphasize this enough when there's trust and respect and collaboration and communication among colleagues.
Yeah, and I'm sorry, I always have something more to say. So, but
No,
I want to
no
just
worries at
build
all.
on that because I want to just acknowledge that there's probably people that this feels kind of pie in the sky and unattainable. I would just give the advice that if you start small but think big, and part of this is just building relationship. And if you have currently an adversarial relationship between these two roles, find some commonality and find something that you can work on together and start there. And oftentimes it's all about this trust and this rapport building and this relationship that will really go far. And if that's eroded or that it's not there and start small but think big would be my advice.
Great, thank you for that wonderful history. And I'm curious, do you see any other industries or like specific organizations through your network or just through kind of hearsay that have similar programs? I mean, it seems to be the consensus that it's quite a mature program, but I'm wondering if you see anybody else doing similar things.
You mean anybody else, like outside organizations?
Yes, yeah, kind of other organizations in different industries.
So we had a very rich and big ergonomics program at the previous places that I worked. I was in the private sector, and then it was actually interesting. My first job as an OC health nurse practitioner was at an on-site clinic in a hospital. So I was the OC health NP for the hospital, and we had a very small clinic, and at that setting, the OC health nurses were also the ergonomists. And
Mm,
of course, we have the education and knowledge and training, but I don't think we can ever give people the gifts that Melanie and her team can give, because this is what they do for a living, and they're the most knowledgeable people. So that's what I've observed in my professional life. I don't know if that answers your question. So there, I've seen a variety of programs and how rich they are.
Yes, that's a great answer. Thank you. And that transitions into another question that one of our audience members asked, another kind of ergo specialist question. Hi, Melanie. What subgroups make up your ergonomic team? So what does it look like structurally?
Yeah, so our ergonomics team, we are aligned with our EHS division, and there are two of us that are full-time equivalents, and then we have two other team members that support us, and we're the ones that address the complex stuff, the industrial stuff, the discomfort ergonomic evaluations. And then the next tier is we have about 90 employees that are embedded into various divisions who are our ergo advocates. This is not their primary job, and they have volunteered to provide ergonomic support. And so my team trains them, we mentor them, we work closely with them, we have reoccurring meetings with those divisional level folks, and they do the preventative office ergonomics that we really feel that they can have great eyes and ears with helping and supporting their peers. So that is what our ergonomics program consists of, is the 2+ people on the EHS team, and then the 90+ people who make this a part of their responsibilities. And many of our ergo advocates, we make it very clear, because we try to have enough of them in each of the divisions, that we know that they have other essential job duties. And so we try not to overburden them with this being anything more than it's a 1 to maybe 3 hours max a week time commitment. So that's something that's very important for us, that we don't want them to get so overloaded with their ergo support that then their other tasks will fall to the wayside.
Got it. Thank you. I have another question. Can you please talk about how to safely and effectively use athletic trainers in on-site health clinics, specifically in addition to nurses and physicians, not instead of them? Curious if you have some, athletic trainers, physical trainers in the midst of the work that you do, or is it something that you would refer an employee to?
We do not have that in our current structure. We would need to refer them, unless Rangineh, otherwise, but that they aren't a part of our core team currently.
That makes sense.
So if I'm understanding your question correctly, the closest thing, so before I answer the question, as Melanie mentioned, we are a national lab, but we happen to be managed by University of California. That means we have a relationship with various UCs in California. The closest thing that I can think of is UC Berkeley has a Work Strong program, and when our injured employees meet the criteria, we refer them to that program. And it's not exactly what the question is asking, but that's the closest thing that I can think of, where people have I don't know if I'm wording this correctly, but they kind of have a personal trainer and who teaches them how to exercise correctly with the correct posture to prevent further injuries. That's the closest thing I can think of.
I'm going to, yeah, sure. Go ahead, Melanie.
I'm sorry, Will. I just wanted to say, we did at one point have on-site OT and PT support services as integrated into our health services. It was very effective, except the volume that we had was not low enough it wasn't high enough to sustain that program. So that was something that we did have in the past, of on-site OT and PT.
So I just sent a link in the chat to that Work Strong program if anybody wanted to check it out. And Melanie, to what you were just mentioning, I have an old coworker in the chat, Elizabeth Sacco-Bassis,
Yay, Liz!
asking, you have on-site nurses and doctors, are you bringing back OT and PT PT anytime soon. But it seems like you answered that question. If you had anything else that you wanted to say about that.
No, I think it was highly valuable to have that partnership. Yeah, I don't know, Rangineh, if you want to say
Wonderful.
anything for it. Yeah, I would not, if someone has the abilities to do that, I would say go for it.
Great. With so much ergo specialists in the audience, I was curious. We do a lot of webinars about new and emerging research in the ergonomics field. It's on, exoskeletons and new technologies. And I'm curious if how you kind of find a way to integrate that research into your work.
Well, I could share a couple of thoughts. Is one,
Mm-hmm.
I am not an early adopter without the evidence-based. Years and years ago, I don't like to base it on the flavor of the month. For example, if there's not solid evidence, so I watch it very closely. We have used exoskeletons in select situations. We are finding great utility in utilizing some of the AI tools sorry, my headset's coming off, to augment as a resource for our ergo advocates, as well as our employees, so that we can reduce the burden. So we're trying to be very agile with looking at how AI tools could help. And then we also do motion capturing software tools to help us with some of our industrial settings, to help with our risk analysis. So those are some of the things that we've integrated into our program. I don't know if that's what the person was asking specifically, but yeah, we try to base it on evidence-based. And one of the earlier questions is, do we know of other people that are doing this? I did want to just mention that if anyone on the call, if you aren't a part of a group and a network of like-minded peers, I would strongly suggest that you find one. For example, I'm in the Bay Area. There's a Bay Area Ergonomics Roundtable that is a bunch of ergonomists that come together and talk. And so there's really, if you feel like you're in an island, it's a good idea to find a network and a partnership. Because we work for the University of California, we are partners with all of our cohorts and collaboratives throughout the UC system. So we have abilities to network and hear the latest and greatest and learn from each other. And then because we also work for the Department of Energy, we actually have a grassroots group of people that work within the Department of Energy that we come together and talk about ergonomics and try to stay on top of the latest and greatest and share with each other little nuggets that we were learning, articles and so on. So that's one way that I try to stay abreast of what the latest and greatest things are.
Is the roundtable, is that the Bay Area Ergonomics Roundtable?
Yes.
Okay, I'm going to send a link to that as well for people.
Thank you. Oh, you had it ready to go. I'm impressed.
So when I asked that question, which was just my question and, running some of these webinars, we got a couple people then wanting to know what motion capture tools you use. It's kind of very specific question, but if you wanted to shout some out.
Yeah, and just I should put a disclaimer that as a Department of Energy, I can't endorse or support or condone, or I can't endorse any products, but we use the Tumeki software to help us with our motion capturing.
Great, thank you. I had a question from earlier, and this I think gets back to, different industries and where you see this elsewhere. And it's a bit of a thinker, but I'm curious if you have any thoughts on it. This was from one of our audience members. In a setting like food service or custodial work where productivity time, errors, etc., might not be tracked at all or may not apply, what type of metrics / deliverables would you suggest be obtained, just in a different type of work where it's not as easy to monitor some of these things? How would you look at, we're succeeding and we're making it better?
I have some thoughts, Rangineh, but if you want to go.
Please go ahead.
Yeah, so I think that's kind of our Achilles heel, is if we're preventing things and we're focusing on wellness, it's really hard to measure that in concrete ways. So some thoughts that come to my mind are asking the employees, asking about their job satisfaction, their workload, getting information from the employees that will help you to know if you're turning the needle in a positive direction or not. Do they feel supported? Do they feel that they could speak up if they have discomfort? Or would they feel that there'd be potential retaliation? So I would really rely on metrics from the employees and what they think, getting their insights, because that's really what will tell you if your program's being effective in their eyes. And I have in the past used comfort surveys as a way of scoring what's your comfort level at the beginning of your day, the beginning of your week, and so on. And so those, the Likert scales and things like that can be very valuable as well of checking in with folks.
Rangineh, did you have anything to add?
No, I agree with what Melanie said.
Great. I mean, I see in your answer so much the emphasis on communication, I think that's been a theme throughout your presentation, and I see it there too, even when we're looking at different types of work and how we would apply the same principles. I have a question from somebody that is related to the second case study, and maybe this can also be a follow-up if you don't have the specific details, but you had mentioned the engineering controls that were implemented, and somebody was asking what they were. But that could also be a follow-up if you kind of have to look back into the notes and whatnot.
Melanie, do you want to take that since it's another ergonomic question?
Yeah.
For lifting and pushing and pulling, what are some of the newer or great suggestions for somebody who pushes, pulls, and lifts heavy weights on a frequent basis?
Yeah, so I'll just speak more in general terms, not just specifically to that case study. So it's where are the objects placed? So if things are down low or up high, can I put them in their sweet spot, in their power zone? So that's often a place to look for an engineering solution, is how I can place it to make it more human friendly. Using any power industrial equipment when that's appropriate. I didn't mention this earlier, but we have a loaner equipment of some material handling equipment that people could check out. We train them how to use it. And some of that equipment is like a stair climber. Believe it or not, we have certain parts of our campus where you can't access them via an elevator. So we have a stair climber resource that people could use. We have height adjustable hand trucks that people aren't often aware of, that can be something that instead of you having to pick up something down low, you can scoot it onto these hand trucks, bring it to the location, raise it up to your sweet spot, and put it where it needs to go. So those are often solutions. So really it's all about the first place that we always go is, does someone have to manually handle it? And can we figure out anything and everything that will create an alternative for that?
Great, thank you for that answer. We're almost at the top of the hour, so I just wanted to do a last call for questions, see if we have any others. Otherwise, we're already getting some great feedback in the chat. Everybody loved the presentation. And if we're all good, we can say thank you to Melanie and Rangineh. Thank you so much for presenting today. Again, feel free to email cohce@berkeley.edu for the slides, and we'll see you all at the next webinar. Thank you.
Thanks, everyone.
Thank
Bye.
you.